Hello everyone, I am Professor TJ Land, and today's content review is for Nursing 421, and we are doing the content that will be on exam 2. So today is October the 7th at 6:30. The first thing I want to talk about is the fact that this exam is divided into two sections. The first section is 50% of your exam. It's all about vital organ decompensation, and we're talking about acute phase here, not chronic. So there's going to be several things that you're going to need to focus on, but it's going to have a lot of information from your first exam, because this is where you're going to need to understand your hemodynamics. Now remember, when I say hemodynamics, there's the basic hemodynamics, which is what you can do when you get a blood pressure, get a pulse, do a cap refill, look at urine output. That's basic hemodynamics. But when I put a PA catheter in someone and I get a PA and a CVP and a wedge pressure, that's actually advanced hemodynamics. You're going to use all of that information to help you determine what organ is failing and why, and the best route of treatment, what that's going to be. So let's get started with the very first one. So Module 4, the very first objective is that you be able to explain how decreased tissue perfusion and impaired cellular metabolism affects organs and organ systems, causes an imbalance in the supply-demand for oxygen and nutrients, and how that's characterized by shock syndrome. Well, this one is very easy. It's a lot of words, but pretty much we already talked about how when things do not get enough blood and oxygen, nutrients, it will change over to anaerobic metabolism, and then at certain points it was actually going to start dying. Now, the more individual cells that die, then eventually we will note tissue damage in your organs. Now, as more tissue dies, then we start getting organ failure. That's kind of pretty much what that's talking about. Now, let's apply that to shock syndrome. Well, that's how this all starts. If we have a patient who has a MAP less than 65, we are not perfusing the kidney. Okay? And if we don't perfuse the kidney, we don't produce urine. Then eventually kidney damage occurs. So in this this session we talked about renal issues. So please remember that we have the 3 stages of acute kidney injury. Those 3 stages can be found in 3 different types of kidney injuries. So that could be pre-renal, intrarenal, or post-renal. Pre-renal is hypoperfusion. We don't get enough blood to the kidney. Intrarenal is where we have had a long enough delay in perfusing the kidney that now we have damage to the actual tubules within the kidney itself. The other option, the other opportunity that can cause this is toxic chemicals. Amphotericin is a very, very strong and toxic antibiotic, and others are the mycins like gentamicin, garamycin, and vancomycin. Those are very toxic to the kidney, and it damages the tubules. Now, when we talk about the tubules in the intrarenal, there's actually 4 phases of ATN. That's acute tubular necrosis. The first one is onset. This is where the damage begins. The second is oliguric phase. This is where we decrease and decrease and decrease our urine output. Now, there's a long period of time between the oliguric phase and then the next phase of being the diuretic phase, because it takes a really long time of supportive treatment and therapy for these patients' kidneys to turn around and go back into the right direction. But once that happens, you're going to know that because you're going to start seeing a better response to your diuretics that you're giving your patient. So once you start noticing that they're having a better response, then we're going to need to back off on the diuretics that we're giving, because we do not want to over-diurese the patient, because now they're moving into their own diuretic phase, and they will naturese. In other words, they will diurese naturally on their own. The last phase actually takes a very long time. That is the phase of, sorry, that's the phase of recovery. And these people usually end up having to go home in the recovery phase and actually visit their nephrologist office, typically in a monthly basis, with labs being done monthly until they see some progression, and then they will go to like every 3 months. The last kind of type of acute kidney injury is post-renal, and those are the ones that cause some type of drainage blockage. So that would be like a kidney stone in the ureter or even in the urethra. Okay, maybe we have BPH. Maybe we have a patient who has a tumor that is pressing on either a ureter or the urethra and is helping to block the exit that we need for the renal system. Now what happens is, when that blockage occurs, the patient's forward flow of the production of urine doesn't happen. Well, if it doesn't happen, it starts backing up. As it backs up, it starts causing more and more pressure backwards, and that will actually cause nephron damage. And then, of course, eventually we could possibly even get hydronephrosis out of that. So definitely something that we want to be concerned about. So Melissa says, how can I get a copy of the blueprint in New Mexico? Melissa, I actually have sent the blueprint to your instructor, Julie, and you should be able to ask her to post that for you. Okay, I hope that answers your question. Okay, so let's keep moving forward. You're welcome, Melissa. So in the post-renal world, we're talking about blocking forward flow and excretion of that urine. Putting the pressure of that backing up damages the nephron, and then that nephron gets permanent damage. And eventually this builds up and we get actually hydronephrosis, water on the kidney, because it has nowhere else to go. So those are actually the issues where shock has initiated tissue deterioration. And it does become a syndrome because the body cannot compensate for that. And when it does try to compensate, it actually makes things worse instead of better. And that's why it ends up being characterized as a shock syndrome. So now the second objective is that you be able to identify the different steps in the progression of shock and describe the management that you're going to do for an individualized care based on evidence-based practice strategies, interventions, and the outcomes that you would like to have. Pretty much what this is is that you need to talk about your nursing process. Okay? So you are going to assess your patient. And if your patient has a low enough situation where the life is endangered, which is in a shock state, so we talk about a MAP less than 65 for renal perfusion. Anything less than 70 is considered abnormal. But we know that the kidney does not get perfusion lower than 65. You also have to know that these things are the things that you're going to look for and assess for. When you see them, you need to interact. So if I have a systolic blood pressure less than 90 or a MAP less than 65, my patient is not stable. I cannot move forward. I have to stop right there. I have to save their life. and then I can move forward after that. So how do I save their life? Well, number one, we are going to fluid resuscitate. That's the very first thing you do for any of the shocks, any shock. You are going to fluid resuscitate until you can determine the cause of the shock and what type of shock it is, and have a more specific treatment plan created based on further evidence and interventions and outcome expectations. So please remember, of course, when we have something like sepsis and septic shock, we don't have a good mortality rate with those types of patients. So, the expected outcome is usually a poor prognosis, but our most wished for outcome would be that we could turn the patients around and do better. The problem with septic shock is the only thing that we can really do for them, other than supportive therapy, is to actually prevent it from happening to start with. So please make sure that you are familiar with your sepsis criteria. Are we hyper or hypothermic? What's our heart rate? What's our respiratory rate? And do I have 2 or more of those? And if I do, then that is criteria to suspect sepsis. If that's the case, you're going to do blood cultures first. You're going to have an order, hopefully for a broad spectrum antibiotic. You're going to get that hung. And you're also going to have fluids going to help keep the blood pressure going. So that's just an example of how the progression of shock happens, and then what do we do about it? So that's the sepsis. Hypovolemic shock, could that be from a trauma? Sure. If I have a stabbing patient that was stabbed in the abdomen, and they actually pulled the knife out and took it with them, so he's going to bleed freely. And if he bleeds enough, that's called hemorrhage. And if there's enough hemorrhage, I will have no blood pressure. First thing I want to do is save his life. So while I have someone else put pressure on the wound, I am making sure that there are fluids being hung to get that blood pressure up. Remember, we're going to use crystalloids. Crystalloids help keep the fluid within the vasculature system, and that's where our blood pressure comes from, is how much fluid's in the vasculature system. After crystalloids, our next choice would be something that actually thickens the blood a little bit. So those would be your colloids, such as salt pore albumin, 5%. Another would be dextran. Another name for that is Hespan or Hep starch. Be very careful with that, because you can only give a liter of that maximum. So it comes in 500 bags, you can give 2, because it will disrupt your coags, and you do have to remember that it does have dextrose in it, and so be very careful of that with your diabetic patients. So how am I going to treat that rotten trauma? I'm going to give them fluids. I'm going to save their life. Once I have done that, then I can step in and be more specific. So if you remember when you read through your trauma information for this particular exam, we have to save their life first. Then we have to do a primary, a secondary, and even a tertiary survey of our patient. The focus of the primary survey is keeping them alive. They have to survive this trauma. The second survey is, now that they are stabilized, what is it that has to be done now to continue to keep them stable, and what can be put off until later? So if I have a fractured arm, I can actually get that splinted and take care of an emergency situation, and then do the arm later if we have to do an open reduction, internal fixation. So we need to work towards progressively improving this patient's status, but we can't overwhelm them. We have to do it in little bits of time. I can't afford someone who's this unstable, this critical, to be in OR and under anesthesia for multiple hours, because they are not going to survive. So now you understand, I've talked about sepsis in the very first one. This time I've talked about a hypovolemic shock, which is a trauma shock hemorrhage shock. All three of those are the same thing. Hypovolemia results in a low blood pressure. Anything less than a 90 systolic or a 65 MAP is a shock state. So we've talked about sepsis, which is a distributive shock. A distributive shock is where we have problems with the vasculature. Typically, it is called vasodilatation that causes that drop in blood pressure, okay? And that's a bacterial or some kind of antigen reaction that's going on in the body. Now, for number 2, we've talked about a trauma, hypovolemic shock, hemorrhage shock. And pretty much, number 1 and number 2 is asking you the same information, just in a different way. How do you identify that? What would be the long-term outcome? What happens when we don't have perfusion? And then, what are you going to do about it? What are you going to do about it? And what do you want to happen when you do that? That's what number 2 is all about. Okay, so you have to be able to do that in all of the shocks. Even though I utilize trauma and hypovolemia as the example, you just need to be able to do it for all the shocks. Now, please remember there are 3 kinds of shock. So there is a hypovolemic shock, a cardiogenic shock, and then there's the distributive shock. Distributive shock, again, is the pipes, your plumbing, your arteries. They vasodilate inappropriately. There are 3 kinds of distributive shock. There's the anaphylactic shock. There's the septic shock. And then, of course, there's the neurogenic or dysreflexic shock. And all of them, you have to initially treat that with fluids to save their life. So moving to the third objective here is, how do you apply your nursing process, you know, your ADPI, to provide the appropriate care individualized for this patient experiencing some kind of shock from an injury or even an infectious disease. So the injury might be a stabbing or a gunshot wound, or the infectious disease might be the sepsis shock, okay? Please remember, if we're talking about sepsis, that is not viral. That is bacterial or fungal, okay? So one of the biggest things is, we've already kind of alluded to that, is we have to assess them. Depending on what we find in our assessment, then we can have our suspicions, okay? We don't make, quote, diagnosis, we make a nursing diagnosis, and that is, we have our suspicions. Then we need to look at, okay, so what kind of labs and x-rays or diagnostic studies do we have, and do they support the nursing suspicion? If they do, what interventions does the nurse expect to do? And what is the next thing that they expect the healthcare provider to order for them to take care of? Then, of course, anything that we do, we have to evaluate whether it worked or it didn't work. And if it didn't work, we have to go back and try a different plan. So we reassess our patient. We have another suspicion. We try to support that with the diagnostics, and then we do an intervention. And then again, we're going to evaluate. We just keep doing that over and over to benefit the patient. So when we're talking about injury, and if we're talking about the infectious process, we're talking sepsis. When we're talking injury, we're talking about some kind of trauma, be that a traumatic brain injury, be that a spinal cord injury, be that some type of blunt trauma or penetrating trauma. All of them are still considered traumas. And they're the same. Any of our shocks, we treat them the same, give them fluids, and then figure out what's going on, and then treat that cause. The fourth objective is talking about you being able to employ that nursing process and create an effective plan of care for those people who are not only experiencing shock, but now they have advanced into multi-organ dysfunction, okay, or even multi-organ failure. So when we've talked about shock, we have a hypoperfusion state, a low perfusion state. Eventually, at the end of that, the tissue that doesn't get the blood, the cells die. And as more cells die, the tissues die. And as more tissue dies, the organ dies. Okay? So this is how we move towards organ failure and organ dysfunction. When we have more than one organ system that is involved, this is multi-organ failure. So let's say that I have a patient who had a sudden onset of chest pain. They collapsed and they were in VTAC and had to be CPR recovered. Okay, so if that's the case, I have to worry about this patient being intubated and having respiratory issues, respiratory failures, right? And then I also have to worry about, is this patient going to be in cardiogenic shock? Because how much damage was done to that left ventricle, and how much can the body, how much can the heart still handle in pumping enough blood out to the rest of the body? So if I have respiratory issues and I have a cardiac issue, then I've got more than one system involved. And so when I have those systems failing, I don't mean respiratory just for protection or supportive therapy. I mean it actually is failing. Like we give them oxygen, they're on an intubator, endotracheal tube, and we have to do a lot of ventilator setting changes because we can't get the patient's respiratory status stabilized. That's a respiratory failure patient, okay? The cardiac failure patient is a patient who has like a global MI in the left ventricle. That means the entire left ventricle has been damaged. The entire left ventricle suffered ischemia and infarct. So that means it's not going to squeeze very well. It's not going to be able to push blood out of it and through the aortic arch and out to the rest of the body very well. So that means we have cardiogenic shock. That's a cardiac failure. Especially if we talk about complete heart failure, a right or a left. These are failures, and when the systems do not function as they're supposed to, then these progressively hamper the patient recovery and even cause further deterioration. Sorry. What you do about that is you have to do supportive care for these patients. And the biggest thing you can do for them is be vigilant, very, very vigilant in your care, meaning be proactive in assessing your patients and suspecting and looking for things and acting on your patient's behalf earlier rather than later. And that's the best thing that we can do to prevent these problems for our patients and to prevent them from getting out of hand so that they may not recover. The fifth one says we need to utilize the nursing process as a framework to develop plans of care for clients who are experiencing the neurological disorders such as stroke, spinal cord injury, traumatic brain injury, intracranial infections and tumors, seizures, and increased intracranial pressure. Okay, so this is the part where we talk about traumatic brain injuries, we talk about spinal cord injuries, we talk about herniation of the brain due to either epidural hematomas or subarachnoid hematomas or even some kind of tumor growth. And if we herniate right to left, that could be a problem. Once the ventricles have moved over into one hemisphere, so let's say, because when you look at it, those ventricles look like a beautiful butterfly. So if one side is squished against the other, you will see that part of the butterfly gets flattened. And when you look at the brain in an x-ray, you see a white line down the middle. Well, that's that fissure that we have down the middle. Once the ventricles are pushed over beyond that center, that's called herniation. And patients do not recover from herniation. Another herniation is called uncal, U-N-C-A-L, herniation. This is where you actually have some kind of pressure, growth, or whatever coming from the top of the brain, pushing it downward. And the herniation is going to occur where the brainstem is being forced through the foramen magnum in the skull. Very, very traumatic. The brainstem's not supposed to go through there. It actually doesn't fit through there, so it actually gets traumatized as that gets shoved out. Now, the problem with uncal herniations is that, please remember, your brainstem is your main control for heartbeat, breathing, the whole 9 yards. That's your powerhouse for your body. If you don't have a brainstem function, then the person is no longer there. The other thing that doesn't allow for the person to be there is a frontal lobe. Now, that takes personality away, but it doesn't take the actual person away, like a brainstem malfunction would. So, some of the other neurological disorders that you have to worry about is, okay, so if I have a spinal cord injury and this person is a quadriplegic from a T6 down, this means that patient will have arm use, but that also means they're going to have bladder and bowel issues, right? They're not going to be under their control. The other thing is patients who have injuries below or at T6 or below, they actually have temperature problems below the site of injury. Not to say that the others don't have temperature problems, they do. But people forget that the ones who can move around and get around better still have that same problem. They take on the ambient temperature of wherever they are. So if they're outside, they're going to freeze to death. If they're inside, they're going to, be okay. If they're outside in the desert in the middle of the day, they're going to burn up. We have to make sure that we're assessing them and treating them appropriately for that inability to regulate their own temperature below any injury sites. I can tell you, you need to know about intracranial pressure. You need to know about it being leveled with the ear, which is actually mid-center of your ventricles in your brain. You need to be aware of an external ventricular device, and sometimes we can actually drain CSF out of the brain and help prevent too much increased intracranial pressure, ICP. We also can control ICP by our blood pressure. So one of the things you need to know about is cerebral perfusion pressure. We call that CPP. This is what is required to maintain perfusion to the brain. Normal is 60 to 100. But if I have somebody who's had some kind of brain issue, it needs to be kept 70 or better. Now, how do I know what that CPP is? Well, this is where I take the map, yes, the map from the blood pressure, and I minus the ICP number, my pressure for my ICP, that gives me my cerebral perfusion number. Please know that intracranial pressure, just the added pressure of any edema, can cause decreases in level of consciousness and actually can lead to herniations. So anytime we have decreases in level of consciousness, we should automatically start looking at, what kind of neurodeficits do we have and where are we going with this? Sometimes they even do burr holes when we have subdurals. Another thing that they can do is do a bone flap, where they actually take a square component of the skull out of the body, allowing a section of the brain the ability to expand for more swelling and edema to be tolerated. Because remember, when everything else in our body swells, there's room, the skin stretches, there's room for it to stretch, it gives. But that's not the case in our skull. It's all hard bone, and there is no room for any kind of increase in the fluid or the edema of what may happen due to some trauma. Because remember, anytime we have any kind of a situation that our body doesn't like, it starts the inflammatory response system, okay? And the very first thing it's talking about is sending a whole lot of white blood cells. And to do that, we flood it with a lot of fluid. And if there's a lot of fluid, I'm going to worry about edema. Putting that in the brain, I have too much intracranial pressure. Number 6, this is the one that's talking about having the ability to recognize when somebody has an urgent or an emergent situation. Please be able to tell the difference between a DKA, which is a diabetic ketoacidosis, and an HHS patient, which is a hyperglycemic syndrome patient, hyperosmolar hyperglycemic patient. The difference is, there are several differences. One is that typically a DKA is a type 1 diabetic. They are not accustomed to having high blood sugars. So anytime the blood sugar gets greater than 250, they start feeling the symptoms right away. They also have ketones that are developed as they have this higher sugar. This shoves them into ketoacidosis, not because lactic acid is being built up, but because ketoacidosis going along with the lactic acidosis is deadly. Okay. Typically, these people survive because, number one, they don't put off going to be seen because they are not accustomed to their sugars being high, so they do not tolerate it well. Now, the difference in that is HHS. That's typically a type 2 diabetic. Up to 85% of those people can actually pass away. That's because they actually make just enough insulin in the pancreas to keep them from going into ketoacidosis, but not enough to handle the high blood sugars. An issue is that they have also been accustomed to higher blood sugars over longer periods of time. So for them to start feeling ill from high blood sugars, it's typically greater than 400 and can be as high as 4,000. I personally have taken care of someone who was in the 5,000. And still being able to walk and talk and have conversations with us, which we were all surprised by that. We worked very hard, and she actually survived. But that's not always the case. You have to work on them. And one of the things is they need to be aware of the symptoms. They need to check their sugars and those kinds of things. The big difference, they both have hyperosmolar situations because it's too osmotic. That's because it's syrupy, right? That sugar content in the blood makes it really thick and syrupy. You also have to recognize that you're going to have a specific gravity problem because when you have high glucoses, you have the 3 Ps, right? Not just the polyphagia, but we have the polydipsia and the polyuria. That polyuria is where the body's trying to thin and wash out the extra blood sugar. The problem is if we don't put enough fluid in for that to happen, the patient can become dehydrated. The other one that really is something that's more emergent that can kill you faster is hypoglycemia. Hypoglycemia is where the blood sugar is less than 70. Your patient will have confusion, lethargy, or even stupor. They will have profuse sweating, and you're not going to be able to get them to concentrate. That's because the neuronal synapses in the body requires glucose for the messages to jump over the synapse. And if we don't have any glucose, we don't get thought process. Therefore, your patients go, huh? What? They're not there. So some people call this a high insulin effect. Well, that could be true. It could be because they took too much insulin. It could be that we gave their insulin and breakfast tray didn't come when we expected it to, and so they didn't eat. So yeah, the insulin kicked in, and so now we need to do something about that. But the other component of that is maybe we've overcorrected it. Because remember, with the increased glucose, we actually have to treat them with fluid to wash that out. We actually have to treat them with an insulin drip. And it's a 1-to-1 mix, so 100 units in 100 ml, so that when 1 unit an hour is 1 ml an hour. And the only one that can be injected is your regular insulin. That's the only one that can be given IV. Now, if we overcorrect the hyperglycemia situations too quickly, we will rapidly move to a hypoglycemic state. Please remember, making our patients worse and potentially even more endangered is not our ultimate goal. So our goal is to decrease hyperglycemias slowly, gradually. Please remember that when you are doing insulin drips, typically they base that on a weight-based, and I believe it's 0.1 per kilogram per hour. And they'll give you a sliding scale to adjust that on. But it's also significant that when you reach about 250, when your sugar comes down enough to be at 250, this is where you need to cut your insulin in half. Your IVs of normal saline at 150 an hour will be cut in half, so that'll mean 75 an hour. And this is when they will add dextrose. So now instead of normal saline at 150, you have D5NS at 75. Your insulin drip will then be cut in half. So if we're running at 6 units an hour, it will go to 3 units an hour. The reason being is we do not want to overcorrect, because it is hypoglycemia is going to kill you, and hyperglycemia, we can manage that before it does. So we do not want to overcorrect too quickly. Please remember that if they're hypoglycemic, if you replace the sugar by IV or even orally, you have to make sure that that's not the only thing you do, because that sugar will be consumed rapidly by the body. So please make sure that you are providing some type of protein for that patient, because proteins take longer to break down and provide better energy. The carbohydrate is fast energy, but the body goes through that so quickly, it's not really going to be beneficial, because just in the next few minutes, you're going to have to repeat that sugar again. You're going to have to repeat the dose of dextrose. There are more, you have multiple slides in your courses that can go over these things in more detail. If you have questions, please do not hesitate to reach out to your faculty member. What I do want you to recognize is that the second half of this is all about your knowledge and how you react to your patients, okay? And so when you have patients who change their condition, hyperglycemic to hypoglycemic, hypoperfused to hyperperfused, when you have patients who change rapidly like that, you have to recognize what's going on in the body. That's your patho. How is that going to affect the body? And then what do you need to do to manage your patients to help stabilize and then maybe prevent more changes that are going to happen very quickly? Okay? So that's what Module 5, Part 1 is all about. We've talked about it already. It's just reinforcing it. Number 2, you need to be able to discuss the interventions that can be done to reduce the risk for patients with this rapidly changing condition. So one of those would be like the insulin. You're going to slowly correct that hyperglycemia. You do not want to do it too quickly because you can throw the body into shock. You can actually overcorrect and then they can die. So we need to make sure that we understand what we're going to do to reduce furthering any risk that the patient may have. One of those, for all of our shocks, we're going to give fluid. Keep that blood pressure up while we try to figure out what's going on and what the best way to treat it is. So for shock, it's all about fluids. Now, please remember that if I have a trauma, the number one problem with trauma is hypovolemia because of hemorrhage, and they end up in hemorrhagic shock or hypovolemic shock. You need to be able to recognize that very quickly. So again, we're talking about your map. We're talking about your stable versus unstable recognition of your patient. And what do? If your blood pressure is low, you got to get it up. If your heart rate's too high, you got to slow it down so the heart has more filling time and do a better job at contracting and getting that blood out. So you have to figure out, is it because my heart rate's too low? Is it because my blood pressure's too low? What's going on here? Please make sure that you review any of your acute cardiac conditions that you had on exam 1 and your respiratory that you had on exam 1, because this is a cumulative exam. Everything is like fair game here because our shock patients are going to have cardiac issues. They are going to have pulmonary issues, and you need to be able to address those with this exam as well as with your first one. Make sure that you understand what your hemodynamics are telling you and that they help you guide your treatment for your patient. We are going to have 5 masks again, so brush up on doing your critical care mask. When we talk about doing like dopamine and dobutamine, we talk about having a dose per kilogram per minute or per hour, depending on what medication you're using. And so you need to be able to calculate those accurately. I actually do not have anything else to share. I'm going to open this up for questions. I would like for you to post them online by typing them in if you have any, so that I can answer them for you. Okay, good. So it looks like we have a pretty good attendance today, too. So again, this is Professor Land with Nursing 421. This is Exam 2's content review on October the 7th of 2015. Please do not hesitate to reach out to your faculty. Please do not hesitate to review any of the PowerPoints. They are a resource for you. And as well as the content reviews that have already been posted. You can find those on the YouTube channel, and you can listen to those as many times as you need to. If you are unable to get there, you can actually go to your campus site and speak to the administrative assistant for that site, and they can actually get that posted in a room where students can view that. I'm hoping that this has been helpful. If you have any issues or concerns, please do not hesitate. Now, I have somebody who says, okay, this is Jasmine, and Jasmine says, was it 1 unit per 1 ml for the insulin drip? Yes, that is how we do the concentration. It is, if I have a 100 ml normal saline bag, then I will put 100 units in it. And that will mean I will have 1 unit per ml. So if I need this to run at 3 units, I will make the pump run at 3 mils an hour. I hope that answers your question. Melissa says, will CRRT be on this exam? Absolutely. That's when it comes talking about whether your patient is stable enough to handle half of their blood being pulled out and put into a dialysis machine. So if they have a low blood pressure because they're hypoperfused anyway, then they're not going to tolerate hemodialysis, where they take half your blood out and you do like 3 hours worth. They aren't going to tolerate that. So CRRT is where you'd have continuous renal replacement therapy. We still use a kidney filter. We still use dialysate. That's the IV fluids we're going to hang. But what we are going to do is we are going to use renal replacement. So every ml that the patient puts out in urine, you are actually going to replace that. So typically, patients have not urinated in quite some time when this is started. And so the physician typically starts out with an IV of 125 mils an hour based on what, and the IV bag is what he wants. Okay? And then you're going to run that, say, at 125 an hour. You're going to measure the urine output in the next hour. And if you have 125 out, then that means you've got no urine, just 125 of your ultrafiltrate. So that means you do not change the IV rate. The next hour, let's say you got 150. Well, that means you had 25 urine output. So now you need to go to your IV pump, and you need to increase it for that hour to 150 to replace the 25 that came out. And so this is an extremely long-term therapy. This takes weeks for CRRT to help a severely ill patient get any kind of recovery from that. So, Melissa, I hope that that's helped you have a little bit better understanding of CRRT. Lauren wants to know if we are going to have to talk about burns. And that is, yes, we are going to talk about burns on this exam. Please remember that you need to be able to recognize first, second, and third degree burns. You need to be able to recognize that the severity, the type of burn, and the length of exposure is going to tell you the severity of the burn. You also have to recognize or be able to do the emergent fluid replacement. So there is a fluid formula. Some places it's called the Parkland formula. Others call it the associated burn formula. It's the same. You need to be able to do the very first 24 hours of fluid replacement for a burn patient. That would be giving them in 24 hours a certain amount. So there's a formula that you use. So it actually calls for either 2 to 4 mils per kilogram per hour. So if the order says that you are to use a minimal fluid replacement, that means you use 2. Moderate replacement means you'll use 3. And maximum replacement means you're going to use 4. So let's say the patient weighs 60 kilos. Well, you're going to do this per kilo. So that means we're going to have 4 times 60, all right? The last part of the formula is the TBSA, which is the total burned surface, total body surface area that was burnt. You guys need to brush up on your rule of 9s so that you can answer questions about the rule of 9s. However, in the exam, I believe we give you the weight and the TBSA. But on the formula, you have to recognize that you don't put that TBSA part as a percentage sign. So if we say the patient has a 30% TBSA and they weigh 60 kilos and we want a maximum amount, we're going to do 4 mils times 60 kilos times 30, not 0.3, but 30. That gives you your 24-hour amount. Then you have to divide that by 2 because you're going to give half of that in the first 8 hours. Now, that's how much you're going to give over 8 hours. If the question asks you, how much are you going to set the pump to run per hour, then you have to divide that to find that out. Because remember, you have an amount per 8 hours. So now divide that by 8 to see how much per hour. So let's say I had like 6,700 mils for my 24 hours. When I cut that in half, that's about 3,200. Well, that's 3,200 in 8 hours. How much am I going to run that per hour? I divide that by 8. It's about 450 mils an hour. So I'm hoping that that helps you have a better understanding of the burns. The biggest thing is please be careful with patients who have inhalation burns, because there's no way to do copious flushing of the bronchial and lungs not without drowning your patient. So all the other kind of burns, you want to profusely wash with fluid constantly, okay? But you can't do that with an inhalation patient. So you have to be very careful with that. Please remember that with burn patients, specifically those who have inhalation damage, those patients, if they die within the first 24 hours, that's typically because of hypoxemia. Hypoxemia. If a patient has, you know, a death after 7 days, typically that's infection. So you need to recognize where we might see some issues for our patients. So I'm hoping, Lauren, that that helps you a little bit better with burns. Do we have any other questions? Please don't hesitate to put them on the chat, please. Okay, thank you very much. This will conclude our session for the Exam 2 content review. I would like to say thank you for attending. And again, please do not hesitate to reach out to your faculty when you have questions, because our goal is that you be successful. Okay? Thank you and good night. Oh, wait a minute. Somebody said something about cranial nerve damage. The only thing you need to know about cranial nerve damage is that you need to know cranials 3, 4, and 6, because that tells you about hippos, which is eye movement. Okay? Eye movement. You need to recognize eye movement, and you need to be able to do a Glasgow Coma scale, and you need to recognize when a patient is brain deaf. You know, what is the criteria for brain death? So the cranial nerves, you just have to know those about 3, 4, and 6. You don't have to know about cranial nerve damage, but the 3, 4, and 6 and what you're evaluating and why. Okay? Sorry about that, Melissa. But that does get actually almost everything. You're welcome. Somebody have another question? You're okay, Melissa. Last minute is sometimes some very important information. All right, everybody. Thank you very much for your attendance. Good luck on your exam. Bye-bye.